Good afternoon, Chairman Stark, Ranking Member Hare, other distinguished members of the subcommittee. My name is Jonathan Hare. I'm the chairman and founder of Resilient Network Systems, which is a software company headquartered in San Francisco. I thank you for the opportunity to appear before you today. To begin, I would point out that virtually everyone in this room agrees that widespread adoption and use of health IT is essential to transforming America's healthcare system, and the HITECH Act that you passed represents a unique opportunity to accelerate that adoption. 18 months have passed since the law was signed, so it's worth asking what progress has been made. My answer is that while much has been accomplished on many fronts, there has been almost no visible progress in addressing one essential challenge: establishing a nationwide capability for secure and private exchange of health information. The HITECH Act specifically provides that in order to qualify for meaningful use incentive payments, providers are required not only to use certified EHR technology in a meaningful manner, but also to demonstrate that such EHR technology is connected in a way that provides for the electronic exchange of health information. The recently released Meaningful Use Final Rule acknowledges this requirement by including as a core objective, quote, implement the capability to electronically exchange key clinical information among providers and patient-authorized entities, close quote. Unfortunately, the measure specified for 2011 and 2012 is to, quote, perform at least one test of the EHR's capacity to electronically exchange information, close quote. There's no requirement to implement authentication, consent, authorization, disclosure management, or any other services that were specifically mentioned in the HITECH Act that are essential to genuinely enable secure and private exchange of health information. Moreover, the test can be performed with dummy data for a fictional patient to avoid security and privacy concerns. My view is this is not really exchange and comes nowhere close to what was intended by Congress when it passed HITECH. It's not good enough. Also, most of the other key measures have been watered down significantly. In fact, some that are most important to improving patient safety and health outcomes were those that were reduced the most or made optional. These include e-prescribing, medication reconciliation, and recording lab values. The justification for the virtually non-existent requirement for HIE is that, quote, many areas of the country currently lack the infrastructure to support the electronic exchange of information, close quote. I disagree with this rationale for a number of reasons. First, in numerous discussions with congressional staffers last summer, I was told that Congress intended these meaningful use incentives really were intended to be incentives, not entitlements. The staffers I spoke with were painfully aware of the repeated failures of previous attempts at large-scale health information exchange. I was told that the HITECH Act's $36 billion in meaningful use payments was intended to create an incentive to figure out a way to overcome these obstacles to HIE. Initial payments were deferred for 2 years until 2011 to give time for innovation to overcome these obstacles. By eliminating any real requirement for HIE until 2013, the final meaningful use rule dramatically undermines the incentives to innovate and to invest in infrastructure necessary to enable it. Necessity is the mother of invention. By eliminating the necessity for HIE as a condition for receiving incentive payments, the final rule also eliminates the incentive to develop the capabilities necessary to achieve it. This creates a vicious cycle where the lack of incentives breeds lack of investment, lack of innovation, thereby perpetuating the lack of HIE capabilities. The dampening of incentives is already visible in state HIE organizations, many of whom have interpreted the 2011-2012 meaningful use criteria as de facto permission to defer serious efforts to create the core services necessary to enabling real HIE. The key words I've been hearing have become back burner, out of scope, and mañana, and I'm too busy. Finally, I disagree with the presumption that secure HIE is not feasible in the 2011-2012 timeframe. The infrastructure necessary for data interoperability exists. It has been demonstrated many times, and it is deployed today. The problem has been the failure to develop a viable approach to connecting applications into a trusted network that enforces security and privacy. The traditional regional and local models for HIE have repeatedly proven woefully inadequate in practice and are incapable of supporting nationwide exchange. I suspect that the administration is well aware of this, which is why they are pushing off the requirement for HIE far into the future. I believe a different approach is possible, a patient-centric network capable of enforcing robust security and privacy policies on a national scale. Such a network would be able to conveniently authenticate and verify identities for any patient, provider, or caregiver, provide robust security enforcement regardless of where the data flows, enable consent and authorization management, records retention, disclosure management, allow organizations to provide access to data without losing control of it, and allow patients to access their own data, to keep track of who's accessing it, and to selectively restrict access if they choose. With proper support, such a network could be fully deployed, tested, rolled out on a national scale within 1 year, making it possible to realize the potential for the HITECH Act. It's time to try something different. I encourage the administration and this Congress to actively explore such alternatives and not let us off the hook in achieving the goals of the HITECH Act. We can do better. Thank you for the opportunity to testify.